I would like to introduce the Dr. Sidiropoulos Prodromos, Professor of Rheumatology, School of Medicine, University of Crete, Director of the Rheumatology and Clinical Immunology Clinic, and University of Hospital Heraklion, Crete. Welcome.
Professor Sidiropoulos, you have 15 minutes for presentation and 5 minutes for questions.
Okay, thank you
Thank
very
you.
much for the invitation. It's very nice to be among the patients, among those persons that we work and we study every day. And so I would like to present the data as I see them for personalized medicine, which is the holy grail of medicine generally, not for rheumatology. And we discussed a lot about new treatments, but now we are going to present, I'm going to try to present the data about how can we choose treatment, which treatment fits for each one of you, and what is called personalized medicine. So this is the menu. What is personalized medicine? Are we close there? Is it available now? And how we can proceed to the best of our targets. So personalized medicine is reported even by Hippocrates. It's the best of the physicians, one who can prevent and predict. So prediction is the core of personalized medicine. So the constant of precision is the ability to tailor treatment decisions based on accurate biomarkers. In the previous discussions, you have heard about dozens of drugs that work in about 60% of the patients. But till now, we don't know which one fits each one of our patients. That's the main issue of our problem in our practice. And I just quote here what Barack Obama said about 10 years ago, and he gave a very nice paradigm. So doctors have always recognized that every patient is unique, and doctors have always tried to tailor the treatments as best they can to individual. This is what we imagine as personalized medicine. And he gave a paradigm with which we are all familiar. So we can match a blood transfusion to a blood type. That was an important discovery. What if matching a cancer cure to our genetic code was just as easy, just as standard? And this is what I'm going to present, what data we have till now. So the traditional medicine that we do every day in our clinic now is that we think that one treatment fits all, which is not the truth. So, and I'm going to refer to data, not many data, just for rheumatoid arthritis, because vast the reference and the literature for all the other autoimmune diseases. So for rheumatoid arthritis, when we have a group of patients, we think that all of them, they are the same, so we start initially treatment with methotrexate, but we know that 60% of those patients are going to respond, 30% are not going to respond, and 15% they are going to experience side effects. Which one of the patients who fits in each one of these categories is not known. And what we try to do now with personalized medicine or precision medicine, which is much more precise and accurate as a title, is to do a treatment that fits each one of our patients. So now the goal is having what we call biomarkers to understand whether there are subgroups within the big group of patients with rheumatoid arthritis, for example. So there are greens, there are yellows, and there are, what is this, blue or purple. And to try to characterize which one of the patient fits to each one of the group. So to try the green drug for the greens, the blue drug for the blues, and the yellow drug for the blues. So to have the best effect in the person level. So traditional prognostic tools to subcategorize patients to predict the outcome have been used in all over medicine and rheumatoid arthritis and lupus and in all our diseases. So I refer to rheumatoid arthritis. So we know about autoantibodies, RF and ACP antibodies, or erosions in radiographs. Only 25% of our patients now have erosions. And then we have disease activity. So we know that those that they have they are seropositive, they have erosion, they have disease activity, they have worse prognosis. But all these, let's say, markers of prognosis have much and great limitations because they have very limited side effects, which means that the additive value that to prognose which one of the patients will have a bad outcome is about 1.5. So it's not very easily and it's not effective to use it in the everyday life. They are dynamic, like disease activity. We measure one day the DAS is 4, the next day is 4.8, because they have subjective measures inside, and they have subjective components. So we have some prognostic tools, but they have severe limitation. So in the principle of precision medicine is targeting a molecular structure like a monoclone, a gene or a gene signature at the best possible level of accuracy may characterize the patients precisely. So we need biomarkers which characterize patients in a very accurate manner. So we have different levels or layers of precision, and we want to go deeper as deep as possible in order to have a more precise characterization of the patient. So here I give you some examples, and in order to understand the limitations or the problems with precision medicine, that in order to increase the precision of a marker, we have some measures, some biomarkers that are not very feasible, and I'm going to give you some examples. So as some examples of precision of tools to characterize our patients, we have the history, like demographics, comorbidities, we have imaging status, and these are all the examples of tools to sub-characterize our patients. But they were very, very easily feasible, but they didn't give us a lot of precision. Now, with tissue biopsy, with system biology, with serology tests that I'm going to present you later on, we have a deeper precision level, but these are not so feasible because they may have an invasive nature, like the biopsies, or they may have a high cost, and we don't know this yet. So what's the perspective? The perspective is based on the peripheral blood or tissues to have a better characterization now with the single cell or bulk cell RNA-seq analysis with the gene expression and not only the gene polymorphism that we used to use several decades before, to characterize different subsets of the cells which are the fingerprint of each one of our patients. And moreover, we use tissues. We have tissue biopsies examples. I'm going to give you some for rheumatoid arthritis, which are analyzed either for gene expression or for flow cytometry and with other what we call generally omics, multi-omics analysis in order to give a very, very precise character of each one of the patients. So rheumatoid arthritis are not only seropositive or seronegative, but they are going to give a very precise fingerprint about what is the RNA-seq signature of what is the gene expression signature of each one of our patients. So we have now all these novel tools, and not only the polymorphism, to characterize each one of our patients. I'm going to give you some examples. So we have these tools. We have done in different places different research. Are we close to what is called precision medicine? So this is the old story. I'm going to give you two only data sets. This was one of the earlier studies we done in Crete with Donis Fanouriakis, who did the analysis. So this was a early arthritis cohort that we have in Crete for several years, and here is an analysis about after 2 years, who of the patients were going to have a bad outcome. Let's say bad outcome, start biologic. We did several analyses here. In the left side, you are going to see the different parameters we used, and we sum up with the usual suspects, let's say. So those patients that have high HAC, they don't function well, or they have high DAS and they do not decrease the DAS at 3 months, we're going to have about twice the risk of starting biologic. So, and this is the character of the data that we have for the last 2 decades. So we have the risk ratios of a patient to start a biologic or to be in high disease activity, but this is not very useful in the clinical practice because it doesn't differentiate our patients very well. I'm not going to bother you with the dozens of trials that they were in which different cytokines, different gene polymorphisms were assessed as predictive markers of whatever outcome, let's say bad function or use of biologics. So there are dozens of them. This is a systematic literature review of this you see here the 1,000 articles, 4,000 articles that they were in this domain. So they analyzed finally 41 articles with different autoantibodies, rheumatoid factor, anti-CCP, different polymorphins of TNF-alpha promoter or the HLAs that are associated with rheumatoid arthritis. What is the conclusion? The conclusion was currently no single biomarker leads to a relevant change in the probability of response. So we don't have, based on all this data, all these thousands of samples that you have provided to all those researchers, a reliable, clinically available tool to predict prognosis. This is the past. What is the advantage now? And this is not only rheumatology or rheumatoid arthritis, in different domains of medicine. So we have advanced the last at least 15 years because we have designed studies on large patient cohorts. And these have replaced the smaller scale exploratory work that have done in several other places before, in the early 20s, let's say. And machine learning tools and the multi-omics that I'm going to present you, so that we have new tools, new approaches to better sub-categorize our patients. And moreover, we don't have only blood. We have synovial tissues. We have kidney tissues. We have skin tissues. We have other tissues, other sounds that they may characterize our patient in higher, what we say, granularity. And in order to have more detailed and precise, personalized fingerprint of the differences that our patients have between them. So I'm going to present only two studies because there are a lot of data. Even our background sometimes is short to analyze and understand those data. And so I'm going to present two data of two European cohorts and studies that, to my mind, are the best for precision medicine in rheumatoid arthritis. So the first study was in patients with early arthritis that haven't been treated before and they received methotrexate. They have peripheral blood and they have synovial biopsies. So there were about 100 patients that they were biopsied in the synovium, in the small joints in the wrist, and they analyzed the tissue according to gene expression. So you may get the cells and have what we say gene expression signature of each one of the patients. So finally, they characterized, to make the long story short, around 13 genes that they could be predictive of an outcome that they set, which was the use of BDMARs after 1 year. So as a predictor of the patient that would have the need of treatment with BDMARs, having in the algorithms genes that were analyzed and they could predict this, let's say, adverse outcome, the predictive value of the algorithm that they had was much, much higher, it's the red one here, as compared to if they used only the classical clinical and radiological factors. So the higher the curve here, and the higher the number here close to 1, the better the marker for the prediction. So if you have the classical clinical factors, so the area under the curve, the AUC here number is 0.8. But if they introduce those only 11 genes there after the analysis they have done, the predictive values goes to 0.9. And it was comparable the result when the outcome they reached, they assessed after 1 year was the radiographical progression. So the radiographical progression, the tool to predict who of the patients are going to have damage, was much higher when they introduced again how many genes here? It was 7 genes. These genes in an algorithm that they had all these baseline clinical and serological factors. So the more the data that you have, the better the algorithm to predict who of the patients are going to develop these erosions. And the second study I'm going to present is, to my mind, the only randomized study that has the biopsy as a tool to select the right drug for the right person. So this is the R4RA trial. This was a pan-European trial. in which the hypothesis was that if you take biopsies and you analyze based on the RNA expression, the gene expression, you may better characterize the patient and have better choices of the drugs. So they took patients that have been treated with TNF inhibitors and they failed. They took biopsies from the wrist and they categorized the tissue as if they have B cells there or not B cells. And so the hypothesis was that if you choose to the patients that they are rich to B cells, to deplete B cells with rituximab, they are going to have a better outcome as compared to treat those patients with tocilizumab with this anti-interleukin-6 receptor inhibitor. So this was the hypothesis. And the interesting thing was that they categorized the biopsies not only to histology, the classical histology, but also to gene expression with a tool they have there, this Phantom 5. So what were the results there? So the results were, to simplify them, that the better or the more granular the characterization of the tissue and the subcategorization of the patients, the better treatment choice you may have. So to simplify here, so the patients that were characterized as not having B cells, according to the histology, they have a less response to rituximab as compared to tocilizumab. But this difference was much higher if the characterization was done with RNA sequencing. And the opposite was in the B cell rich population. So to simplify that for you, if you analyzed the tissue, only the tissue, forget all the other parameters, and you categorize the patient if they have B cells or not, based on the RNA sequence, the gene expression, not the histology, then you get a biomarker that it may predict responses much better. So you see here that if you are low to if you are low to B cell, 36% of the patients respond to rituximab, whereas it's 50% when they are rich cell in B cells. So and there was a second part of the same study where they analyzed the tissue. I'm not going to get into the details. It was a very nice study. Not only to this tool, but they have full gene RNA expression, and they characterized even more granular the tissues. And if you see here, the odds ratio, the higher risk of having a response if you if you are treated with tocilizumab as compared to rituximab was 16. This is the first time that you can see a number like this. You have 16 times more risk to be a responder to a drug if you have a tissue biopsy and you analyze based on the RNA sequence analysis, as compared if you don't have this information. Just remember with the RF, the CCP, the erosions, the odds ratio is 1.5, 1.8. Here is 16, okay? So, but what are the problems that I see? These are the goods. I'm not going to repeat them here, but the limitations here is the need of biopsy, and that these data have not been validated in other cohorts. It's about the cost. And if I ask you, who of you would like to have a biopsy before getting a drug, I know how many of you will be positive. Let's make a poll. But if I sell you that if you get the biopsy, I'm going to have a better choice for you 16 times, you may think a second time, okay? So are we there? So these are the limitations to my mind. The immune system, because the gene expression is the gene expression of the immune cells, lymphocytes, monocytes, and also fibroblasts. So it's increasingly dynamic, have plasticity, and in both in short and long terms, the lymphocytes are not every day the same. Establish the determinants of response to therapies in given individuals includes genetic susceptibility, environmental factors, and patient and drug-specific factors. All are dynamic. And the readout, we always care about remission, is not stable and it's not very objective sometimes, okay? So we have problems with the tools that we use. So the right therapeutic choice for a given patient is not just a drug that induces remission, but we have that you have to agree with the drug that we propose, let's say rituximab or tocilizumab, that we have to judge the risk and the benefit that we are going to have, and to take also into account the comorbidities. We don't treat all patients with B-cell depleting therapies. And we have to be cost effective, and sometimes all this information that we are discussing are not so widely available, and they are not being validated in other cohorts, in many cohorts. So to my mind, what we have to do, and your role is very, very important. So I think that, and this is something that we are doing in Europe and in the United States, to expand the well-organized patient cohorts combined with biobanking of peripheral blood and tissue. We don't have to have 50 patients or 100 patients. We have to have hundreds and thousands of patients very well organized in registries and combined with biobanks in order to share with the other researchers. We have to expand the cooperation between rheumatological centers. We have to go and discuss with each other, with other European centers, and this is something that we're doing in the context of European collaborations. We have to discuss and collaborate with big data experts, bioinformaticians, big data analysts, those that they do artificial intelligence. We have to get profit of reanalyzing towards biomarkers, discovery of and rediscover the vast, diverse existing data around Europe, around academia, around the big pharma. There are thousands and millions of biosamples that they are there. We have to go and reanalyze them. And this is something that the European Union is supporting. And of course, the patient's role, your role, is very, very important here. So your role is, to my mind, to set up the studies together. We need your input. We need your encouragement. We need to hear your goals. We need to hear your perspectives. Your role, it's not only to provide the biosamples, but it's very, very important. It's to provide with other multiple data. That's why we are very keen of selecting many, many other questionnaires. And of course, your role to all this story is to disseminate the good results. And I don't know how aware you are with these results. I think that although we are not there yet, for the next many years, and this is something not in the rheumatological field also, but the oncology field also, we need to discuss and to set the goals for precision medicine. Thank you. There is a question.
Good afternoon. Today I would.
Can I just a quick comment and on a very nice and very quite innovative presentation, because normally we just hear about treatments, innovative treatments, and that's it. Precision medicine, I personally think it's the future. But when you say expand, I think we should expand to several other areas also, because with the use of machine learning, AI, and the whole area of research, I think phenotyping and omics, in other areas, it's at the moment we have innovation and quite recent findings and quite interesting findings and really nice findings that the rheumatology field can absolutely make use of. Pain, gastroenterology, even neurology can make use of, like rheumatology. We can share and we can look into what the other areas are finding and how they are doing that, methodologies. So expand to other areas maybe, and use what's out there already. So one is this. And when we say collaborate, it's not just being there, as you said. Collaborate means empowerment, knowing and being inside of what's happening. And at the moment, we're not that close and ready to collaborate actively in such a high level. We're getting there, but we're not already there. We should do more, all of us, to train, to educate ourselves and get there, because it's high level stuff. We need to go there. Yeah, thank you.
100% with you.
do you think that the health systems, generally in Europe, they are ready for this kind of treatments?
I think that not even the research community is ready. So we have a long way to go.
Because we are seeing that in cancer, they are doing a lot of precision medicine, but not on any other kind of
So
diseases.
the beauty of cancer, let's say beauty in quotes, it's that the genetic background is much more different. So you may do this genetic analysis because normally genetic analysis, they don't have other tools there in order to do the precision medicine. It's not the same here in rheumatoid arthritis, in ankylosing, in lupus, which are polygenetic diseases with more than 100 genes implicated. So it's a totally different area.
One photo.
Okay, let's go forward very fast. Can we present the Professor Kumbouros, which is not with us? It is a pre-recorded video. Can we show that? Thank you very much.
Good afternoon. Today I would like to talk about how artificial intelligence, or AI, is transforming rheumatology. For many years, we imagined AI as a future tool, but the future is already here. These technologies are no longer abstract ideas. They are already influencing the way we diagnose and care for patients. AI has already moved from research into daily practice. Algorithms now help doctors detect early signs of disease, analyze X-rays, and even suggest personalized treatments. In rheumatology, which deals with complex diseases like rheumatoid arthritis, lupus, and psoriatic arthritis, AI is helping us reduce diagnostic delays and improve treatment accuracy. Let's explore some recent examples in order to understand the potential that AI brings to the field. One exciting development is remote assessment. For example, the Mephisto system can analyze hand movements through video and AI algorithms. For rheumatoid arthritis patients, this means they can be assessed at home without traveling to a clinic. This is especially valuable for those living in rural areas or for people with mobility challenges. In this video, you can see how researchers leverage single-camera motion capturing as a digital biomarker for disease activity in rheumatoid arthritis using computer vision. This proof-of-concept study investigated the association between hand motion tracking features obtained through computer vision on smartphone cameras and disease activity in rheumatoid arthritis patients. Hand motion tracking offers promising possibilities for remotely assessing disease activity in rheumatoid arthritis patients, enabling telemedicine and improving access to care. One limitation of the current systems for hand motion tracking is the reliance on dedicated camera systems and/or sensors, which may not be readily available in all clinical settings or for remote patient monitoring. Deep learning has the potential to enhance hand motion tracking significantly. Another key area is medical imaging. Artificial intelligence is revolutionizing diagnostic imaging in rheumatology. One striking example comes from research on sacroiliitis, a key feature of axial spondyloarthritis. Traditionally, detecting these subtle changes on X-rays requires years of experience. A recent study showed that deep learning systems trained on thousands of radiographs can identify sacroiliitis with an accuracy comparable to expert radiologists who have over a decade of clinical experience. This means that AI could soon serve as an assistive tool, ensuring earlier and more reliable diagnosis, especially in settings where access to subspecialists is limited. For patients, This translates into faster detection, earlier treatment, and potentially better long-term outcomes. AI systems using convolutional neural networks can look at X-rays, ultrasounds, or MRIs and detect small erosions or signs of inflammation that even experienced clinicians may miss. A study in Nature Medicine showed that AI achieved diagnostic accuracy similar to senior radiologists. For patients, this means earlier diagnosis, more confidence in test results, and quicker treatment decisions. Artificial intelligence isn't just about images and scans. Another breakthrough is the use of large language models or LLMs. These are systems that can read and process enormous amounts of medical text, including guidelines, textbooks, and research papers. One well-known example is Google's Part2. In a recent study published in 2024, this tool was tested on difficult medical exam-style questions. The model achieved an accuracy of 67.2%, while experienced physicians scored around 72% on the same test. This means that AI systems are now approaching the level of human experts in understanding and answering complex clinical questions. What does this mean for us in rheumatology? It means that in the near future, doctors may use these models as quick assistants. For example, instead of searching through dozens of articles, a rheumatologist could ask the model for a summary of the latest treatments, guidelines for lupus, or a patient could receive clear explanations of lab results in everyday language. Of course, these tools are not meant to replace doctors. They are meant to support us and help patients get answers faster and more reliably. One of the most patient-centered applications of AI is in personalized care and remote monitoring. Thanks to wearables and smartphone apps, patients can now track their symptoms, activity, and quality of life on a daily basis. For example, a recent 2025 study published in Annals of Rheumatic Diseases followed adolescents with juvenile idiopathic arthritis and familial Mediterranean fever for 3 months. These young patients used smartwatches together with a Activity mobile app, which recorded their step counts, fatigue, spinal mobility, and pain levels. Doctors then used this data to better understand daily disease activity outside the clinic. This shows how digital tools can make care more personal. Instead of waiting for the next hospital visit, a doctor can review data from the patient's daily life and adapt treatments earlier. For patients, it means feeling heard and involved in their own care. For doctors, it means having a clearer picture of what's really happening in between appointments. Another exciting frontier in AI is what we call unsupervised learning. Unlike traditional methods, where we tell the computer what to look for, unsupervised AI algorithms search for hidden patterns in large amounts of data. A 2024 study in the Annals of the Rheumatic Diseases analyzed patients with systematic lupus erythematosus using unsupervised clustering. The AI system grouped patients into distinct subtypes based on immune cell profiles and B-cell subsets, something doctors had not clearly identified before. These subgroups showed different treatment responses, especially to biologics like belimumab. This means AI can help us move away from a one-size-fits-all approach. Instead, it can identify which subgroup a patient belongs to and guide doctors towards the treatment that is most likely to work for them. For patients, it means a faster path to effective therapies, fewer side effects, and a more personalized care journey. AI brings incredible opportunities, but we must also be cautious. Studies show that if AI is trained mostly on data from certain populations, it may not work as well for others, for example, patients with different ethnic or genetic backgrounds. This is called algorithmic bias. To prevent this, new European regulations require hospitals to validate AI tools locally and ensure patient privacy is respected. This way, AI can be used fairly and safely for all. Another consideration is related to the ownership of the data. And of course, how do we ensure that these tools are accessible not only in wealthy countries, but also in places with fewer resources? Despite all the promise of AI, adoption in real clinical practice is still limited. A 2025 scoping review from the ULAR Digital Health Network showed that while rheumatologists are very interested in AI, over 70% reported that they have never used AI tools in their routine work. Why? The main barriers are lack of training, uncertainty about how to interpret AI outputs, and concerns about legal responsibility. This shows us something important. It's not enough to build the technology. We must also adapt our medical education. Doctors and nurses need training not only in using AI, but also in understanding its strengths and weaknesses. Future curricula for rheumatologists are likely to include AI literacy, for example, how to evaluate whether an algorithm is reliable or how to use AI systems alongside clinical judgment. This ensures AI becomes a trusted assistant, not a black box. To make this more concrete, let me share a real-world example. In 2022, a study by Saleh and colleagues developed an AI system trained on thousands of X-rays from rheumatoid arthritis patients. The goal was to see whether AI could reliably identify joint damage caused by RA. The results were impressive. The model achieved a sensitivity of 94% and a specificity of 91%. In plain terms, this means that the AI was almost as accurate as highly experienced radiologists in distinguishing diseased joints from healthy ones. Why does this matter? Because in RA, early diagnosis is everything. If we detect disease activity earlier, we can start treatment sooner, prevent irreversible joint damage, and improve long-term quality of life. This study shows us that AI is not replacing doctor, but it is becoming a valuable assistant, making diagnosis faster, more consistent, and accessible even in places where radiology experts are scarce. Several AI models have demonstrated high accuracy in early RA detection using imaging modalities such as thermal imaging and nuclear scans. Predictive models for treatment response have leveraged routinely collected electronic health records data, moving closer to practical application in clinical workflows. Patient-facing tools like mobile symptom checkers and large language models such as ChatGPT show promise in enhancing education engagement, although accuracy and safety remain variable. AI has also shown utility in identifying novel biomarkers and accelerating drug discovery. Despite these advances, as of early 2025, no AI-based tools have received FDA approval for use in rheumatology, in contrast to other specialties. AI holds tremendous promise to enhance clinical care in RA from early diagnosis to personalized therapy. However, clinical adoption remains limited due to the regulatory, technical, and implementation challenges. A streamlined regulatory framework and closer collaboration between clinicians, researchers, and industry partners are urgently needed. With thoughtful integration, AI can serve as a valuable adjunct in addressing clinical complexity and workforce shortages in rheumatology. To conclude, AI is no longer science fiction in rheumatology. It is already improving diagnosis, treatment, and patient engagement. The future we imagined is here, but it must be used responsibly. With collaboration between doctors, patients, and technologists, we can ensure AI truly improves lives and reduces the burden of rheumatic disease. Successful clinical AI implementation requires addressing challenges regarding data protection, interpretability, ethics, and clinical validation. Here you can see a recent research on using chatbots for answering rheumatology-related questions. Another research studied the development of a virtual twin of the synovial joint in rheumatoid arthritis. Thank you very much for your attention. I would be more than happy to be able to collaborate in the near future. The Digital Innovation in Public Health Research Lab of the University of West Attica is currently working on the latest technologies to support research in the examined domain. You can find out our contact details in this slide. Thank you.
Thanks. Okay, I would like to introduce Dr. Magiorkinis Gikas, Professor of Hygiene and Epidemiology, Scientific Coordinator, National References Center of Retroviruses. And the subject is vaccination and RMDC, what patients need to know, medical perspective.
Okay. Thank you very much for the invitation. So when I received the invitation, I thought what patients need to do or need to know generally about vaccination, and it has been a controversial field, I would say, in the mind of the patients for at least 100 years, as we're going to see. And so the correct word instead of vaccination would be immunization, because vaccination is derived from, let's say, one of the first types of ways to immunize. Vacca in Latin is the cow, and we will see how this happened. But before vaccination, there was variolation, and that existed for hundreds of years, and people were taking biologic material from people that had smallpox, and with different ways, they inoculated that material to non-patients to immunize them in a way that it could be safer to develop immunity. And indeed, only 1 to 2% died due to variolation compared to 30% due to natural infection. And that practice seemed to be deep in time, and there are different historical sources showing that it started in China many, many years ago, and by many, many years ago, I mean before 1500. But there were differences between the way that the inoculation was happening in China, in India, but also in Sudan. Interestingly, one of the first, let's say, medical letters that described the practice was from Lady Montagu, that she showed the variolation in Constantinople by 2 Greek doctors. They performed it. That was Emmanuel Timonis and Iakovos Pilarinos. And after she saw that she had a very, she suffered a lot from smallpox, she almost died. So she thought, this is the way to protect my 2 children. So she performed variolation in her 2 children, and they were both okay. And then when she went back to the UK, she performed variolation in 6 prisoners who, let's say, were if they survived, they would be released. And not just they were variolated, but then they were exposed, and that they did not suffer from the disease. So she actually showed that the practice was safe, but also effective. However, in around 1800, Jenner inoculated the 8-year-old James Phipps from a milkmaid with cowpox. And the reason that he did that, which was more or less similar to what was variolation, but this infection from cowpox is much milder, so it has less side effects and provides almost the same protection. So it was, let's say, the first safer way to immunize an individual. And this is the start of modern day vaccination, which then, as it was very, very effective, we had, by the late 1800s, the first laws about vaccination. And firstly, variolation was banned because it was more dangerous. Then vaccination, at the same time, vaccination became free, so people would not have to pay for that. And in 1853, vaccination became compulsory and fines were imposed to parents. If that makes you think of something that recently also happened. And then we had the first anti-vax movement, and after a lot of pressure in 1898, parents were allowed to obtain a certificate to not vaccinate their children based on ethical reasons. So history comes back again and again, and you can see cartoons here about how people felt about the vaccine. You can see like small cows jumping out from places from different parts of the bodies, and also a cow here eating children, like it was because people thought that was, let's say, dangerous, or it was doing harm to their body. So it's even that it was not ethical because you are putting animal material on the sacred human body. Here we can see one child. These two are brothers. The one was vaccinated, the other one was not vaccinated, and you can see like how much that kid almost died, almost. So you can see how effective it was. We haven't seen this picture since, if you recall, smallpox was eliminated in 1980 around, so we haven't seen such. And you can see like since 1800, a lot of vaccines have been developed. And it was very, very intensive, the vaccination production after 1980. And here we can see how effective it has been. So you can see the, I don't know. No. Anyway, like soon after the introduction of different vaccines, the incidence of very deadly disease, I would say, has dropped significantly. There is no question that vaccines have changed the hygiene and the life expectancy of children, but also of the full population. However, vaccines evaluation, apart from that, let's say, experiment on the prisoners, was not, let's say, systematically performed. It was not until 50s until we had the first phase 3 clinical trials of vaccines. That was the polio vaccine. Over 1 million children was vaccinated, and showed that it is safe and effective. And even though we have a very effective vaccine of polio, since then we have not been able to eliminate the disease. Another thing that I think it's very important for everyone to know are like the vaccines is not just one type, there are several types. And one of the most important is what we call the live attenuated. It means that you are being vaccinated with an organism that actually lives at that time point. It is attenuated, so it's not very strong, but it is likely to develop some sort of disease. And then we have the other types, which are not alive, so they are considered safer compared to the live attenuated. However, usually the live attenuated provides a more full protection against the disease. And there are like all of these different types. I won't say a lot. So very briefly, how do vaccines work? Well, they mimic how natural protection is produced. So you get let's say, the antigen. The antigen is the material that let's say, the disease, the microbe is made. And then this material is being recognized by a series of cells, of immunity cells, in order to be able to produce a response that will be able to stop infection if and when infection happens at a later time point. So one thing that people are asking is, okay, I'm doing the vaccine, am I fully protected? Well, not exactly. You are not being protected in a way that you won't get infected at all. There are different mechanisms that vaccines work, and that depends a lot of how fast the pathogen will develop the disease. If the pathogen is slow, then you are likely to have the response that you will produce. You are likely to be able to respond to it sufficiently. If the vaccine is very fast, you are unlikely to be able to respond at it sufficiently. Most of the times this is the case, but you're likely to be able to fight the disease in better terms. So why should I get vaccinated? Firstly, of course, as I said, there is the possibility to not get infected at all. But if you get infected, you get a milder disease. And all the vaccines that are circulating now, they have been evaluated with respect to the benefit risk. Because everything that we do in this life have a risk. Even when we drink water, we might get drowned by the water that we drink, but we have to drink it. So the benefit is much higher than the risk that we have. The same is with vaccines. These are being thoroughly evaluated for the benefits that they provide to the specific population that they are provided, and they are compared always with the risk. So yes, they are being tested thoroughly for safety and efficacy, and there is a big vaccine life cycle, which involves 3-phase clinical trials until they get licensed, and then there is a phase 4 where vaccines are being monitored for very rare events or interactions with other systems. Anyway, this is how vaccines are being evaluated, and this is the same if you do it really fast, as we did it with COVID-19 vaccines, or with vaccines that need more time to be evaluated. Again, you can see I wanted to focus here on the 3 phases that involve vaccine testing. And you can see that we start with a small human population and we grow. We get a few individuals to see if the vaccine is very dangerous and how likely it is to be effective. Then we go to a larger phase. Again, we see if the vaccine is efficient and also if it is likely to be effective. And in phase 3, we test against very hard, let's say, very high standards if the vaccine is both safe and efficient. And then there is an approval process. There are committees that evaluate all these phases about the, let's say, the risk-benefit ratio. And this is what we have in Greece about the vaccination of children and adolescents. I won't go into in very much into depth. There are different, let's say, suggestions about which need to be performed to the whole populations and other vaccines that need to be targeted against specific patients. And you can see here different colors are the suggestions with about patients with specific diseases. For example, HIV infection, immunosuppression, asplenia, and chronic myocardiopathies, etc., etc. So there are, apart from the general population, we have disease-specific suggestions. And this is for children and adolescents. This is available to the Ministry of Health the website. It's this list is evaluated once every year by the Committee of Immunization in Greece. And this is the vaccine schedule for adults. Again, this is age dependent. You can see like the categories of different ages that need to perform different vaccines, or what vaccines are suggested for each age category. And then we have again the same that about what vaccines need to be performed depending on the disease that they have. Now, now we'll try to focus a little bit on autoimmune disease. And there is, of course, we know that these patients are at increased risk of vaccine-preventable infection. And a general rule says that we should try to vaccinate the patient in the let's say, the phase where the disease is milder, and also it is when the patient does not receive immunosuppression. So if possible, planning vaccination before starting immunosuppression, especially if it involves the B-cell depleting treatment. Now, non-live vaccines can be administered during treatment with specific immunosuppressions. However, as I said, if you remember, I told you there are the live attenuated vaccines, a very specific category, and this needs to be considered with caution. Probably in most of the cases, you should avoid having such a vaccine. One of the major concerns that we have heard from patients is that vaccination may cause an exacerbation or progression of the pre-existing disease. However, all clinical studies that have been performed show that that vaccination should be performed, and there is not a link between vaccination and autoimmune disease. I think the only exception is Guillain-Barré, which is not exactly an autoimmune disease, a chronic autoimmune disease, but it is also caused by the let's say the infectious agent, and in all cases the vaccine has a much lower incidence of Guillain-Barré compared to the infection. Now, studies have shown neither increased incidence nor exacerbation among vaccinated and unvaccinated. I will show you some of them. This one is specific for systemic lupus, does not induce increase of lupus activity or flares. The HPV vaccine, another study in New England Journal of Medicine. This is multiple sclerosis, not, of course, a rheumatic disease, but it is an autoimmune disease, and some people have been thinking, as I said, generally not vaccinate against in people who have autoimmune disease. There is no increase of short-term risk or relapse in multiple sclerosis. Again, in JAMA neurology, the same for other vaccines. So these are the EULAR recommendations for vaccination in adult patients with autoimmune inflammatory rheumatic disease. So there is a strong indication for influenza and pneumococcal. The herpes zoster is recommended in high-risk patients. With respect to HPV and tetanus toxoid, general public recommendations should be followed. Hep A and Hep B for at-risk patients, and provide probably boosting to prevent, as I said, to increase the immunity due to immunosuppression. Yellow fever should always be avoided, only if it is absolutely necessary. Now, a couple of very interesting points. Immunocompetent household members of patients should be encouraged to receive vaccines according to national guidelines, with the exception of the oral polio, because the oral polio is a live vaccine, and it can be transmitted to the patient with the immunosuppression. As I said, live attenuated vaccines should be avoided. Look, first 6 months of life in newborns of mothers treated with biologics during the second half of pregnancy. And of course, all of these are not, a patient cannot know all of this. So they have to consider the individualized vaccination program by the rheumatology team, and always provide the basis for this shared decision making. So it's always a decision by the patient, but the rheumatology team has to provide as much information as possible so the patient makes an informed decision. Thank you very much.
Do we have any questions? One or two?
Uh, I believe that COVID will return somehow, probably. What do you think about the COVID vaccination, especially in autoimmune diseases? Because as in our experience, some patients have passed away due to COVID vaccines in our country anyway.
Which vaccine was applied to the patients?
Pfizer.
Yeah. To the best of my knowledge, the thing is, what happens with vaccines is always, with respect to the medical doctors, is that we are trying to extrapolate our own experience to the general population, which is not the case. We always see the hardest cases. So we see the rare cases, and this is also happening with the side effects. So I suspect, while I don't know the cases, all the case control studies and etc. have shown that there's no signal. They are rare, but they are like, let's say, more likely that a patient that has not been vaccinated will die due to COVID rather than due to COVID vaccination. And that's how the committees work. They always weigh the balance, the risk and the benefit. So, to the best of my knowledge, and to what all the studies have shown, is that they are very safe, and this is the safest, let's say, option that you can do to vaccinate or not to vaccinate. You should always try to vaccinate. Thank you very much.
We have a vote. Thank you. Okay, let's move on. And last but not least, Mrs. Evangelia Bakola, who is a health visitor and health mental coach. He's going to speak about the vaccination and childhood and adolescent vaccination in the context of pediatric rheumatic diseases. You have 10 minutes.
I
Thank you.
understand that. Okay. Just to be sure that you can understand my English very well, please let me read some words from here. Hello. Our focus will be on childhood and adolescents vaccination in the context of pediatric rheumatic disease. These patients are uniquely vulnerable because both their underlying disease and the treatments we use increase the risk of infection. Vaccination is therefore a cornerstone of their preventive care. Over the next 15 minutes, I will summarize the latest evidence. Mr. Majorkinis told us about the EULAR 2018. We talk about the 2021 EULAR's recommendations. You should also understand the safety profile of inactivated and live vaccines in this patient group, describe how immunomodulatory therapies affect vaccines responses, and apply this knowledge in clinical decision-making. Ultimately, the goal is to equip you with practical advice that can be shared with families and adolescents living with rheumatic diseases. Pediatric autoimmune and inflammatory rheumatic diseases, often abbreviated PEDERD, include conditions such as juvenile idiopathic arthritis, systemic lupus, erythematosus, and the pediatric vasculitis. These conditions require long-term immunosuppressive therapy, which places patients at an increased risk of infection. Understanding the interplay between disease, treatment, and vaccination is crucial in pediatric rheumatology practice. Children with rheumatic disease may experience serious infections, complications, ranging from pneumonia to varicella and opportunistic infection. The risk is amplified by the use of corticosteroids, methotrexate, biologics, and targeted therapies. This reinforces the importance of proactive vaccination strategies to protect against preventable disease. So why vaccination matters? Vaccination matters because it prevents hospitalization, reduces mortality, and safeguards quality of life. For pediatric RMD patients, infection can derail treatment, cause flares, or require prolonged hospital stays. Thus, vaccination is not a minor preventive measure, but rather a critical intervention that underpins long-term disease management. National immunization schedules. Mr. Majorkini shows us the national schedule here in Greece. National immunization schedules provide the basic framework for vaccination. However, in pediatric rheumatology, adaptations are needed to account for the patient's immune status and the medications they are taking. Clinicians must ensure that children are as close to up-to-date with their vaccinations as possible before starting immunosuppressive therapy. The ACR 2022 guidelines emphasize the importance of inactivated vaccines for all patients with RMDs. They recommend vaccinations ideally prior to initiations of immunosuppressions, but also encourage catch-up vaccination where possible. They provide drug-specific advice, including holding methotrexate temporarily around influenza vaccination to improve immune response. The Euler Press 2021 update aligns with these principles but provides more pediatric-specific recommendations. It stresses that inactivated vaccines are safe in immunosuppressed children and should be administered according to national schedules. For live vaccines, they recommend careful timing relative to immunosuppressive therapy, ideally before treatment or after adequate washout. Inactivated vaccines such as influenza, pneumococcal, meningococcal, to DTaP, to HPV, and hepatitis vaccine are all safe and effective in pediatric RMD patients. Their administration is strongly encouraged even during immunosuppressive therapy, as they reduce the risk of common but potentially severe infection. Live attenuated vaccines, such as MMR, Varicella, and rotavirus, require more caution. The evidence base is expanding, showing that many children tolerate these vaccines well, but the risk increases with high-level immunosuppression. When possible, live vaccines should be administered prior to immunosuppression or delayed until the medication has been stopped long enough for immune recovery. So, this chart illustrates how vaccine responses can vary depending on therapy. Healthy controls typically mount strong antibody responses. Patients on methotrexate often have reduced responses. Those on TNF inhibitors retain intermediate responses, and those on rituximab show profoundly reduces responses. These findings highlight the need for strategic timing of vaccines relative to therapy. Let us consider a case. We have a 12-year-old girl with polyarticular. JIA is stable on methotrexate. She is due for her HPV series and her annual influenza vaccine. Both of these are inactivated vaccines and should be administered according to schedule. Evidence suggests that pausing methotrexate for 1 week after vaccination may improve immunogenicity, provided the disease remains well controlled. Our second case is an adolescent with a systemic lupus erythematosus receiving mycophenolate, mofetil, and a biologic therapy. This patient has a higher level of immunosuppression, which may blunt vaccine responses. Nevertheless, inactivated vaccines remain safe and are still recommended. Live vaccines, however, should be avoided while on this regimen. Timing is everything. Vaccination is ideally performed before starting immunosuppressive therapy, but this is not always possible. When patients are already on therapy, clinicians must weigh the risks and benefits of vaccinating versus delaying. In general, inactivated vaccines should not be delayed, whereas live vaccines must be carefully timed with medication washouts. Certain medications require adjustments. Methotrexate can be paused briefly around vaccination to improve immune response. With rituximab, the recommendation is to wait at least 6 months after infusion before administering live vaccines, and ideally to give inactivated vaccines just prior to the next infusion to maximize response. High-dose corticosteroids are another consideration, often necessitating delays for live vaccines. Decision-making can be supported by algorithms. A typical approach begins with assessing the level of immunosuppressions. If low of moderate, most inactivated vaccines can proceed. If high live vaccines are avoided, this structured process ensures patient safety while avoiding unnecessary delays. Communication with families is essential. Parents often worry about whether vaccines will trigger flares or side effects. We must explain that the benefits far outweigh the risks and provide clear, right plans so families know which vaccines are recommended and when they should be given. This builds trust and encourages adherence. Frequently asked questions include: can my child receive all vaccines? When exactly should live vaccines be avoided? What if my child was exposed to biological therapy in utero? So, the take-home messages are clear. Vaccination is crucial for children and adolescents with rheumatic disease. Inactivated vaccines are strongly recommended and safe, even under immunosuppression. Live vaccines can also be safe in select contexts, but require individualized planning. Multidisciplinary coordination among rheumatologists, infectious disease specialists, and primary care providers is the key. The Panhellenic Associations of Health Visitor has started a campaign for the HPV, and that's a leaflet that we create and use to this campaign across the country. Thank you.
Do we have any questions? Okay. We'd like to thank Mrs. Bacola, and let's give us your present. Before that, I would like to inform you that we have to be at the lobby at 4:30 or 4:45, and if some of you have your cards with disability, proves your disability, please bring them with you because we are going to need it at the Acropolis Museum. Okay, don't forget to be 5:25, 4:25, 4:30 at the lobby. Okay? Thank you. Not much. We're not going to walk. We're going to be at the bus, going sightseeing, and then we're going to, the bus will going to leave us very close to the Acropolis Museum, just 5 minutes.
You will walk.
You will
because
walk,
it's a
okay?
big museum.
Just take to give the present.